exam. I know. All right, now, CNS drugs, central nervous system drugs. So we're going to talk about that a little bit today. But basically, these are going to be drugs that act on the brain and the spinal cord. Now, I told you that the blood-brain barrier is a wonderful thing. It protects the brain. On the downside, that may mean that there's going to be a delay for effects. So if you're trying to treat pain, or if you're trying to treat different type of psychiatric disorders, those medications are going to take a while before you begin to see clinical effects. And it's really, 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 really hard to convince your patients to take it every day, and they may not start to feel better for 30, 45, 60 days in some cases, okay? So the production of anesthesia, that is quick, all right? You want drugs that are going to put you to sleep quickly. So those are very highly lipophilic drugs, okay? They get to the brain about your second breath for some of the inhalation anesthetics, okay? Some of the IV medications, yeah, I'm pathetic. Count backwards from 100, wah. And then I wake up and they go, okay, well, when are you guys going to start? Oh, we're done. Really? That was fun. All right? So, now, I'm going to talk a little bit about non-medical uses. Why do people abuse these CNS drugs? Okay? Because they want to get high. That's not their intent. They were not designed to produce a high. Okay? However, the people that use recreational drugs, or drugs recreationally, okay, they're looking for a better high. And it's like, why? Why? All right? Well, there's actually a website. And the name of the website is spelled out EROWID.org. You can go to that website, and they will give you ways to get high. Thank you, Internet. Okay? And they'll tell you how to do it. They even have pharmacokinetic discussions on this website. Okay, how to make your high last longer. Now, was that the intent of the researchers when they were designing these drugs? Absolutely not. And for some cases, it's like, well, shoot, I'm going to take that because I feel really good. Okay? Some of our pain medicines will make you feel really good. Okay? You may end up doing some really stupid things, but you feel good. But that's not the intent. That's not the intent. Mind-altering activities, this website will tell you what kind of plant seeds you can chew up and ingest so that you can experience hallucinations. And they'll give you the dose. Okay? It's interesting reading. This is something that your patients have access to. If you have teenagers, anybody in the room that has teenagers, familiarize yourself. Familiarize yourself. Arrowwood.org. And, you know, that's actually the word weirdo jumbled up. Yeah. All right? So, the transmitters of the central nervous system, okay, neurotransmitters, acetylcholine, norepinephrine, epinephrine. So you guys have already heard about those, right? Okay? Well, so, you know, this is nothing new this close to the exam, all right? Now, there are 21 other compounds that are used as neurotransmitters in the brain. This is your introduction to them, okay? How much of this stuff is going to be on the test? Not much. Okay? Not much. However, if you think that there's not going to be a question on acetylcholine, norepinephrine, or epinephrine on the test, you are sorely mistaken. Okay? All right? Now, neurotransmitters. All right, we have the monoamine neurotransmitters. Okay, so these are our catecholamines. And just another word for this class. Dopamine, norepinephrine, epinephrine, and then the newest member, serotonin. Okay, we will talk about serotonin later in this semester. And again, and again, and again. Okay? Serotonin is one of those compounds where they're constantly finding new receptor subtypes. And we're actually creating drugs that are only going to affect this receptor subtype. And we're beginning to treat various disorders. Serotonin receptors are actually throughout the whole body, but we'll talk about it mainly right now. Yeah, it is one of the neurotransmitters. Serotonin is one of those that helps with your mood. Your happy drugs are serotonin stimulants, or they will block the reuptake of serotonin. So there is something out there to stimulate the postsynaptic serotonin receptors. How many serotonin receptors? I believe they're up to 30 different subtypes. Okay? It's hard to keep up. But for now, serotonin is in the central nervous system. All right? And then the purines. All right? Another class of compounds. So adenosine can be a neurotransmitter in the central nervous system. Okay? And by looking around the room and noticing, okay, some of you are drinking water, others, I believe that's your dose of caffeine. Caffeine actually works at the adenosine receptor of the brain. Oh, wait a minute, I just snuck a little extra pharmacology in there. All right? The adenosine receptor in the brain. We also have adenosine receptors on the heart, and we'll talk about those when we talk about cardiovascular medicine. AMP, so cyclic AMP, adenosine monophosphate, adenosine triphosphate, is actually a neurotransmitter in the central nervous system. And you only thought that that was part of mitochondria. No, there are parts of your brain that actually use it as a neurotransmitter. Okay? So these are, and we're starting to see does this help with psychiatric disorders? If we affect the ATP receptors or AMP or the adenosine receptors of the brain. Okay? Adenosine itself doesn't cross the blood-brain barrier. Amino acids. So here we go, a little bit of biochemistry. You have to have amino acids. You have essential amino acids in your diet. And if you picked up a multivitamin bottle, it'll say, okay, the following are essential amino acids. And it will list them off, and it will tell you how much is in that particular vitamin capsule. But aspartate, GABA, glutamate, glycine, GABA, I've already talked gamma aminobutyric acid. Okay, I've already talked about that once. And that's an inhibitory neurotransmitter. Aspartate and glutamate, those are excitatory neurotransmitters. Okay? So when your alarm goes off, yeah, aspartate, glutamate, those blood levels or the brain levels go up so that it wakes your brain up. Okay? If it goes up too much, then you might start to have seizure activity. Okay? Yes, ma'am. They are excitatory amino acids. GABA is an inhibitory. Glycine is part of the interneurons within the spinal cord. Now, your textbook says we don't really understand glycine. The textbook is right. All right? And that's why it's not on the test. But glycine is actually a stimulatory amino acid, mainly in the spinal cord. And glycine's role is part of where, when you do tendon reflexes, So it's part of the reflex arc. It's the neurotransmitter that the spinal cord will release so that it'll stimulate that muscle so that you get muscle contraction and you can see their knee jerk. Okay? So glycine has roles, and it also has roles in the brain. So we do have glycine receptors in our brain. So these are our other neurotransmitters. Opioid peptides. Your brain makes feel-good drugs. Okay? So your dynorphins, endorphins, enkephalins, all are derivatives of ACTH, adrenocorticotropic hormone. Okay? Adrenocorticotropic hormone is a huge chain of amino acids, and certain little clips will actually stimulate the opiate receptors. And so for those of you that say, well, what makes you happy? Well, going out and running 21 miles, that makes me happy. I don't know about that. But if that makes you happy, great. Your brain is being stimulated by its own neurotransmitters for that feel-good sensation, the runner's high. Okay? Or that's why after you go exercise, or I used to be able to say this, you go exercise and it's like, yeah, I feel good about my workout today. Usually I'm just thrilled that I can get through the workout and still be breathing. All right? So there are also some non-opioid peptides. So they do not work at the opiate receptors. Okay? And for this list, substance P, all right, substance P, it's like, okay, we actually now have the structure of that, and it's got this great big long chemical name, but it's just easier to remember it as substance P. And that's actually the neurotransmitter that tells your brain, ow, that hurts, P for pain. Okay? And we actually have a series of arthritis drugs so that you can decrease the pain for those arthritic patients. And it basically depletes substance P as a neurotransmitter. Pretty cool, huh? So is their range of motion better? Sure, because it doesn't hurt. All right? Somatostatin, oxytocin. Oh, so oxytocin, that's part of labor and delivery. We actually give that as a drug. Vasopressin, it can actually be given as a drug. Okay? So these are peptides that we give our patients. Okay? And they're part of the interconnections of the brain. Okay? And acetylcholine is actually in another category, and histamine. All right? For those with allergies, all right, yeah, histamine is not your friend, is it? All right? Antihistamines are your best friend if you have severe allergies. Okay? And certain days it's like, oh my God, I don't even want to get out of bed. Okay? Histamine is a neurotransmitter in the central nervous system. I can get a histamine response by a simple scratch on the skin. That localized reaction is from histamine. Histamine is actually stored in many, many different cells of the body. So, but it is a neurotransmitter in the central nervous system. So that's why when some of you take certain types of antihistamines, your first effect is because ion block, histamine helps keep your brain just a little bit awake. Okay? So, the blood-brain barrier, gotta remember that lipophilicity. All right? Lipophilicity. So, protein-bound drugs, things that are highly protein-bound. So, a lot of our psychiatric medications are highly protein-bound. Another reason why we have a delay. The blood-brain barrier, they're lipophilic, but they're so highly protein-bound, the albumin says, you can't have it. You're stuck over here on this side of the blood-brain barrier. So there's another reason why these patients need to be taking this for months before they get clinical effects. Plus the blood-brain barrier itself Because what we're actually doing for some of these CNS drugs is we're affecting all of those different neurotransmitters. And in some cases, it's multiple neurotransmitters. So how fast do you think that process takes? It's a slow process. You actually have to affect biochemical reactions within the brain. Okay? Now, this for some can be confusing, but for most of our CNS drugs, we stumble upon them. Okay? Who would have thought that if you take fruit juice and let it sit at room temperature for weeks on end, to actually drink that? Why? Well, when fruit juice breaks down, alcohol is formed. I didn't. But who did the first dose of alcohol? Okay? And then they went, either I like the way this makes me feel, or, ew, I never want to experience that again. Okay? So, it's one of those just, as a species, humans are curious. Here, let's see what this is going to taste like. Okay? So, they scrape the mold off the top and they'll either eat it or drink it. Okay? And there are some people that will actually ingest certain types of mold because they found out that can produce a high. Okay? To me, if it's fuzzy, I try to avoid fuzzy things. All right? All right, so now, for the CNS, it's like, well, the structure, this is where the chemistry comes in. You won't have to worry about the chemistry, but the structure, if I change the structure a little bit, well, it sort of kind of looks like norepinephrine. You do some tests, it's lipophilic. That means it should get to the brain. Can we give it to patients that have a brain norepinephrine deficit? Absolutely not. But we give it to patients and they go, look at this effect. Okay? So we guess, all right? And for most of our brain diseases, we really don't understand everything very well from a pharmacology standpoint. From a pathology standpoint, we may have an exact etiology of the disease, what starts it, how it progresses, how it worsens, all of these different things, right? The pathologists always have the answer because the patient's already dead. Well, why didn't you notice this? Well, that meant that I would have had to cut the brain up into itty-bitty little slices and looked. And we really hate that when we start slicing the brain up. Okay? Sort of kind of needed. All right? So we can guess what this drug is going to do. We can guess its side effect profile. We can give it to normal healthy volunteers because it's actually, here in the United States, it's illegal to give it to those with a psychiatric disorder. Okay? And we take notes. Or we have the patient keep a journal for us. How did you do? How did you feel? Okay? And so we stumble on a lot of our psych medicines, all right? So basically, we're going to try to then we'll ramp it up. Do things change if you take it every day? Do you get better, or do you get worse? Okay? If you've ever seen, there's a movie that came out, Flowers for Algernon. Okay? Yes, it's an old movie. It's in color, though. It's not BC, before color. All right? Interesting study of patients in a psych facility. And we thought we had a cure for some of those psych disorders. Okay? So over time, we actually found out that the brain goes, I'm tired of getting beat on, so I'm just going to go back to the progression of the disease. But for a while, those patients got significantly better. So we saw increased therapeutic effects, all right? And for our psych drugs, we're still trying to get a handle for a lot of our different psychiatric disorders, okay? So, you know, your friends are, well, since you're taking this Pharm class, pharmacology, I have this friend that takes this drug, and this is how it makes them feel. Your response should be, I'll get back to you on that. And then you go look it up, okay? Because it may not make sense that they're taking this for something way over here. But if you go to look it up, it's like, okay, and I'm trying to give you that basis so that you have more and more of those aha moments, all right? So, adaptation of the central nervous system. Your central nervous system adapts. Thank goodness we adapt, okay, over time. And basically, that's why the beneficial effects can be significantly delayed for a lot of our psych medications, a lot of our CNS medications, with the exception of anesthesia. Okay? Our anesthetic agents, we can go, okay, here's the chemical structure, it's similar to this. If I give it this way, dunk, we should have. Now, what am I looking for with different anesthetic agents? How quickly you fall asleep, how long you stay asleep. How great is the risk for respiratory arrest while you're under anesthesia? And you also need to understand for some of the anesthetic agents, well, you know, is it liver metabolized? Is it toxic to other organs? And so on and so on, okay? But in the lab, we can actually look down at the synaptic function. How does this work? Your question about epinephrine with local anesthetics. Why do we start doing that? Well, we just figured out how it's being metabolized. So if I want the local anesthetic action to last longer, we put a little epinephrine in there, okay? And again, telling the patients that this is going to take some time. You're not going to feel any different for 2 months. How is that going to make you feel if you were on the receiving end of that information? We are a society of immediate gratification, aren't we? I want to take it and I want to feel better now. Correct? Yeah, okay? And so drug companies are trying to get the feel better now in the forefront. Okay, and you'll see that information in the television ads. Okay? Now, decreasing the side effects, we may have to adjust the dose. Because for a lot of these medications, how much gets to the brain? How good is your blood-brain barrier compared to my blood-brain barrier? Are they exactly alike? No, they are not exactly alike. So we may have to adjust the dose. You give them a dose, yeah, you could put them to sleep. Okay? And that's not a good thing. Those patients aren't going to take it if they can't have daily function. I don't even feel like getting out of bed most days. Okay? You know, the example that at this point, morphine is taken to control pain. The big side effect of morphine is the nausea, especially early on. For some people, oh, I'm allergic to morphine because it makes me so nauseated. To me, that is not an allergic reaction, that's just a side effect, because if you were able to take it long enough, that nausea actually goes away. Okay? So you're going to encounter this. Yeah, do you have any allergies to medication? And they start rattling off. And it's one of those, well, what kind of reaction did you have? It's like, If any of you have ever taken an antibiotic, oh, I'm allergic to it because it makes me nauseated. I don't know of an antibiotic on the market that if you take it by mouth, that it doesn't make you nauseated. Okay? To me, that's just a normal reaction. Yes, it's a side effect. But that's going to make a lot of people know I'm allergic to it because it makes me nauseated. Really? Okay? So, and for antibiotics, actually, it's the opposite way. The more you take it, the more nauseated you get. Okay? And we'll talk about antibiotics later in this semester. So these are things, so we are going to adapt. We adapt. Now, tolerance. That question came up yesterday. I can't remember who asked me the tolerance question. Okay. All right. Tolerance. Decreased response. Morphine is a good example. Opiates are a good example. Decreased response. Or there are those that take drugs recreationally. Okay. I could pick on alcohol as a drug. I think everybody knows they have that uncle. Okay, they got that uncle, all right, that can drink a half a gallon of Jim Beam and drive himself home. Tolerance. If I drank that much Jim Beam, I'd be in a coma. Okay, I'd be in a coma. But Uncle Bob, that's just getting started. In fact, a physician friend of mine said, yeah, I've got a patient routinely ends up in the emergency room because occasionally he will overdo it. He will come in and, so do you drink? Mm-hmm. How many drinks a day do you have? 2. A half a gallon before lunch and a half a gallon after lunch. And that's his definition of 2. Okay? 2 bottles. All right? And he'll drive himself to the emergency room and go, Dr. Dave, I think I overdid it today. He knows when he's overdone it. His tolerance is that high, but he's that in tune. He's afraid that if I go home and go to sleep, I will stop breathing in my sleep. So he drives himself to the hospital. Now my buddy, Dr. Dave, doesn't bother drawing labs because he gets these blood alcohol levels that are astronomically high. He should be dead. Tolerance. Okay? He said, I'll put him on a cot in the hallway, and we're busy on a Friday or Saturday night when he tends to overdo it. So people just walking by, okay, let's just, keep bumping him as you walk by. He continues to breathe. He's there for 4 or 5 hours. He'll wake up and go, okay, I can go home now. You will encounter those patients, okay? Your Uncle Bob, all right? Now, for this particular patient, I will continue to use this patient of Dr. Dave's physical dependence. If he stops drinking, so if for whatever reason, okay, it's a holiday and he forgot to buy his 2 drinks, okay? His blood alcohol level starts to fall. He starts to experience withdrawal. His body has adapted so well, it needs it to function. What happens if his blood level falls too low? He starts to have seizures. Seizures. The drugs don't stop. What's our drug of choice in that case? Well, we don't give him a complete drink. However, we'll have a family member bring in some alcohol for him. That'll help stop those seizures. Okay? The body needs it. The body wants it. He will crave it. Okay? And these guys, you can tell when it's time to try to get them out of the emergency department because they will develop the shakes. They need a drink. They get that drink, and they're perfectly fine. Before the drink, they can thread a sewing machine while it's running. Okay? Physical dependence means that if we stop giving it to you, you have a withdrawal syndrome. And that when we get to certain drugs, I will re-emphasize that point. But alcohol is a good one. Alcoholic patients, if we suddenly stop, so we have to actually bring their blood levels down very, 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 very slowly so that they don't have seizures. Or if we're bringing them down in a hurry, then we'll have to start them on anticonvulsants, because if they start to have seizures, okay, see the problem with dependence? Tolerance means I just got to take more to get the same clinical effect. Okay? And you're going to see patients where if the patient tells you, okay, you need to start that IV right here in between these two toes, they're probably a IV drug abuser. They're going to need much larger doses of pain medicine to get the same clinical effect as the patient in the next bed. Okay? Mental health is, there isn't a blood test. Oh, you have mental health. Okay? No, you're anemic. That's easy. All right? So the animal models, okay, and have you ever seen a depressed rat? Yeah, so is there an animal model for depression in rats so that we can try this drug to see if the rats act less depressed? So, depression, there are stages of depression, okay? And stages of excitation, but really and truly, is there, can you look at a rat? Yeah, that one's depressed. Oh, no, that one's not. All right? So we have poor animal models. All right? We can guess that these might work. All right? And ethically, we cannot give medications to patients that are mentally ill. Because if it's a new drug, we have to have them sign informed consent. If you have psychiatric disorders, are you truly informed before you sign? Okay? So a lot of these we kind of stumble on. All right? Again, small advances, major therapeutic breakthroughs, although you'll see the drug companies advertise that. Okay? So basically we have lots and lots of neurotransmitters that we're messing with in the brain. Okay? 21 different neurotransmitters and counting. We're coming up with more neurotransmitters as we better study the brain. So if I give one chemical, one drug to affect a certain neurotransmitter subtype, I might be affecting this one and this one and this one. And the really scary thing is that rats may not have those in their brains. Yes? Yeah? I reserve the right to change the lectures. Because, guys, as we get down closer to the exam, it's like, do they really need to know how to believe? So, yes.
Oh, sure. Question. On the previous slide, for the physiological dependence, what was the definition? Was that just like the examples?
The examples that I elaborated.
Okay.
Your physiology has changed, so you gotta have it. Okay? Nicotine's another one of those gotta have it kind of compounds. All right? My mother in coffee, she had to have it. In fact, growing up, so Mom, how many cups of coffee do you have right now? And it wasn't until she got her third that we would burden Mom with anything else. All right? Now, treatment of Huntington's disease. Yes, ma'am.
So, for question 24.
Uh-oh. 24. May I borrow yours?
Yes, sure.
Okay. Question 24. Describe how, in many cases, control of key activities in the CNS involves more than one neural pathway, each with its own neurotransmitter. That's why I went through all of the neurotransmitters. Because if I mess with one, I could be affecting 6 others over here. And is the brain perfectly wired? Were we talking like this? No. It goes here to here, back to me, over there, okay? And so the crucial thing is that the wiring in the brain isn't 100% understood. What are our neural pathways, okay? We have the big pathways, but so the interconnections, what controls what? We're still getting a handle on that. Do we fully understand the human brain? Absolutely not. Okay? And we keep finding more neurotransmitters. Why is there a receptor for cannabis in the brain? The body doesn't make a receptor unless it's got a neurotransmitter. We haven't found the cannabis neurotransmitter, the endogenous compound. Okay, it's like, All right, wait a minute. Well, my professor said, no. All right, so for Huntington's disease, does that help? Because this is why it's not an easy answer for these disease disorders. And Huntington's is my best example of that. Because can we give a drug to solve the deficit? Unfortunately, no. Okay? Is it, and we think it might be acetylcholine and GABA. And we think that it might be that their neurons are dying that are producing the acetylcholine. We think. We're not sure. So we're still guessing. That's why, are there a lot of drugs to treat Huntington's disease? No. Chapter 107. How many drugs are there? 1.
So you say that it's the HCA, chapter 1?
For Huntington's disease, it seems to be acetylcholine has a bigger role. Okay. We think. Today. Next month, we may have some other research that counters that. Okay? So we're still trying to get a handle on it. I mean, yes, we know it's a genetic disorder, right? Okay? For those that have been studying for the exam, yes, it is a genetic disorder. We're trying to figure out what causes that mutation. And really and truly, because you have that mutation, why is it that not everybody gets Huntington's? Okay? So what's different about their brain with the mutation and their brain with the mutation? They have full-blown disease. This patient is perfectly fine. Okay? So this is what makes this brain stuff very, very difficult. Okay? Tetrabenazine it is what is being used. Basically, it reduces the availability of dopamine in the brain. Because in the brain, the balance between dopamine and acetylcholine, so we're guessing, it's sort of like Parkinson's disease. Okay? The imbalance between dopamine and acetylcholine. And basically, we're also using this drug for patients with Parkinson's disease to help restore that balance between acetylcholine and dopamine in the brain. Okay? So we're guessing. We're guessing at this point. All right? Adverse effects. Look at that. Suicide and depression. All right, the depression gets so severe, and you can actually increase their mobility to the point where they can actually act on those thoughts of suicide. Okay? Extrapyramidal. So Parkinsonism, akathisia, dystonia, all right? And that's part of the vocabulary words that I gave you, okay? Understanding what those are. I gave you some YouTube videos so that you see what these snake-like movements of Huntington's disease, okay? Can you have daily life when you're moving that much? Okay? Now, for the longest time, we've been giving first-generation antipsychotics, all right, haloperidol being one of them. But these aren't approved. I put big asterisks up there because we are guessing. We're using the side effect profile of haloperidol because it upsets the balance between dopamine and acetylcholine. It's great at causing Parkinson's type symptoms. It's great at causing dystonias. Okay? So why not try it for a patient to see if that helps control their movements with Huntington's disease? God, I'm using the side effects of a drug to treat a disease. How logical is that? Okay? The second generation antipsychotics, the extrapyramidal reactions are much less. And they're not used that much because they're not that effective. So we're using the side effect profile of these medications to actually treat a disease. Okay? Multiple sclerosis. All right? There's 6 immunomodulators, according to your textbook, right? And I'm going to talk about 4 of them. But interferon dimethylfumarate, glatiramer acetate, and natalizumab. And they say that generic names are easier to pronounce. Okay? All right? Interferon is actually a natural product. Your body makes interferon in response to a viral load. We find that's how the body fights off viral infections, or these various interferons. So it's one of those where it's like, fights off infection. It's got to have something to do with immunomodulation. Okay? So big doses of interferon beta, and there are a whole host of these. There's beta 1, beta 2, beta 3, just interferon beta at this point. Okay? Don't worry about the nitnoid details before exam 1. Just know that interferon beta is given. It basically reduces the frequency of the attacks for the disease. And if you also look at, there's actually brain lesions that are formed, and if you're doing serial CAT scans, it reduces the number of lesions. So it's like, oh, I have evidence that this is perhaps the causative agent for this evidence. Fewer lesions, that's a good thing. All right, lesions in the brain, bad thing. Okay, what's one of the biggest cause of lesions in the brain? Football head injuries. Okay. All right. So, reducing the frequency of the attacks. Ooh, that's a good thing. Okay. So these are and probably the very really important one, delays the progression of the disability. It does not stop it for a lot of patients. I can delay the progression. Wait a minute, they might have normal daily life functions as through their adult life. Is it going to stop them from progressing as they get older and older? No. Okay, if they were going to progress, they're going to get older. Now, adverse effects, flu. All right? So for those of you that have never had the flu, your hurt actually hurts. Your muscles hurt, you ache, you have a low-grade fever, your hair hurts. Even my hair, what little I've got left, will hurt. Okay? All right? The aches and pains of the flu, the fever of the flu, after every injection, And you have to teach the patient how to give themselves this injection. Well, wait a minute. If I give myself this shot, it makes me feel like crap. What's their compliance? Yeah. So usually, if we tell them to take something like Tylenol just before they dose themselves, the flu-like reaction is less. Okay? So acetaminophen, it can be hepatotoxic. And since we are affecting immune function, the rest of that. Neutralizing antibodies. Your body will produce antibodies against interferon. How good is that? This is a natural product that your body uses so that you get over the common cold, so that you get over that viral attack, and a whole host of drug interactions. So it's not the ideal drug, all right? Dimethyl fumarate, relapsing multiple sclerosis. So these are patients that are fine, and they'll continue to be fine, then all of a sudden they won't be, okay? And it's also, they're finding out that another autoimmune disorder, psoriasis. So your body is starting to reject its own skin, okay? Its own skin. So it is an immunomodulator, and basically they all will promote apoptosis of activated T lymphocytes. Apoptosis, that's the fancy word. You're in college now, so we have to use fancy words. All right? Apoptosis, that's part of the death cycle of cells. Okay? So, and it inhibits the migration of lymphocytes into the central nervous system. You sort of need them there, okay, to protect your brain against infections. Oxidative stress, we're going to go into that in more detail than you would ever imagine after exam 1. Oxidative stress, okay? So at this point, now, adverse effects, that's not bad. Flushing, GI discomfort, lymphopenia, you don't have enough lymphocytes. What do lymphocytes do? Fight infection. So that's why if you see the television commercial, the trade name is Tecfidera, and they have television commercials of this particular product 2 or 3 times during the nightly news, every day. Okay? So, and as they start talking really fast at the end of the commercial, you think, why the heck would you want to take this drug? Okay? How safe is it to take? Well, when you wipe out your lymphocytes, they're really important in helping you stay healthy. All right? Decrease your body's responses to vaccines. Can actually, if you get the wrong type of vaccine, where you've got a live virus vaccine, you can actually get the disease that you're being vaccinated for. You thought you were going to prevent the disease. Here, I'm going to give you a shot, and that's going to, if you're getting ready to travel abroad, there are some of those vaccines that are live viruses. Oh, and dimethyl fumarate actually stops that, and you end up getting the disease from the shot. That's not so good. Okay? Glatiramer, all right? Relapsing remitting MS. And the only reason that I put the different types of MS is because is it used for all types of MS? Not really. Okay? So there are different forms of multiple sclerosis. Remember, but okay. Do I need to know those different forms and how to differentiate? No. Just know that we have different drugs for different forms. Okay? Just know that there are different forms of multiple sclerosis. I don't want you to try to understand all the pathophysiology behind each one of those forms. Okay? Yes, ma'am.
Is the interferon data only given to patients with multiple sclerosis, or is it also given for...
Oh, it's given for a lot of different uses. So right now, today, the answer to your question, no, it's only given for patients with multiple sclerosis. When interferon comes up later in the course, and actually there are subtypes of the interferon that are given for different diseases, because we found out that the all the different forms of interferon beta. Well, it's one of the subtypes that does a better job for different diseases. Okay? But for right now, interferon beta, as of right now, all I want you to remember is, yes, multiple sclerosis. Okay? So if the question talks about using interferon beta, multiple sclerosis. All right? Later on in the course, it's like, well, there's multiple sclerosis and we'll fill in the blank later. Okay? All right. Now, Gladimir is well tolerated, does not cause the flu-like symptoms. Oh yeah, this is an injection also. It does not cause myelosuppression, so it doesn't affect muscles. All right, and it doesn't poison the liver. Well, that's pretty good. All right, poisoning the liver, and really. They can't find it. They're still looking, but right now, as of right now, this publication, no significant interactions with other multiple sclerosis drugs. Because are these patients given one drug? No, absolutely not. We're trying to figure out how to solve this problem, so we're giving them multiple medications. All right. Natalizumab. Now, when I said that generic names were easy to say, that's where I said, well, I think they named them by throwing Scrabble tiles on the table and going, okay, this is what we're going to call it. Okay? Now, usually if you see MAB, M-A-B, okay, that's an that's the tail end of an immunoactive compound. So right now, these are immunosuppressants. So if you see a television commercial where you see MAB as part of the name, oh, that's an immunosuppressant. Be prepared for that fast talking at the end of the commercial about them trying to get all the infections and no trouble. Okay? So, now, I think this is kind of cool. This drug actually helps to prohibit leukocytes from leaving the vasculature. Leukocytes stay in the vasculature. Yes, ma'am. Mm-hmm.
It's not an anti-alloler or immuno...
Modulator? Well, you could, okay, potato, okay. It's one of the, it depends if you're a true immunologist. And I don't want to make you guys immunologists. If you start to treat these patients, you're going to go back and go, well, he only gave me just the very tip of the fingernail kind of information. Well, I'm trying to get you through the tests. I'm trying to get you through what you need to know for med-surg and stuff like that, when these drugs will come back. Okay? Now, if it's preventing the white blood cells from leaving circulation, uh-oh. Okay? And basically, white blood cells, if you get too many white blood cells going to one neighborhood, and that happens to be a neighborhood in the brain, that's called a lesion. Lesions are bad. Okay? All right? However, white cells need to migrate. Okay? Look at this list of most common reactions. All right? Do I want you to memorize that list? No. The very bottom ones, the most serious effects. Serious, come on, no. These can be fatal effects. All right? Progressive, multifocal, leukoencephalopathy. All right? I got it out, didn't I? I had to practice that. All right? All right. PML. That's not a side effect we like to have in a drug, because the leukocytes will take over multifocal, many different areas of the brain. Once they figure out, oh, we need to go there, then the leukocytes start digesting the brain. Oops. Really didn't mean to do that, Mr. Winter. Okay? All right? And of course, hypersensitivity reactions, yeah, you can become allergic to it. Here I'm trying to treat your disease and you become allergic to one of the few drugs that actually works. All right? And it's also very toxic to the liver. All right, myasthenia. All right, so myasthenia, autoimmune, okay, autoimmune to the acetylcholine receptor. Got antibodies to your own acetylcholine receptors, and mainly the acetylcholine receptors, mainly at the neuromuscular junction. Okay, so that's why it's a movement disorder. All right, and if we can get more acetylcholine than antibody, then maybe we can maintain some muscle strength. Okay, so therapeutic effects, neostigmine, tablet form, easy to swallow. But wait a minute, some of these patients can become so weak they cannot swallow. Okay, so this is something that they have to assess. Here, drink from using a straw. Okay. Therapeutic levels, the CNS is mildly stimulated because of all of the acetylcholine we got going on in our brain. Okay. Toxic levels, it'll shut the brain down. Okay. It'll shut most organ systems down. Too much acetylcholine. So this drug has a very narrow therapeutic index. What's therapeutic and what's toxic are almost side by side. Okay? So neostigmine, tablets, adverse effects can actually, all of the adverse effects at this point, so far in this class, we just learned that it's excessive muscarinic stimulation because the acetylcholine receptors, the nicotinic receptors at the motor end plate are the most affected. But you have to remember, acetylcholine has muscarinic. Okay? What are the muscarinic symptoms? Don't worry about learning those now. I'll tell you when you need to learn them. Okay? For those that have already learned them, great. You're half a step ahead. All right? But you have to remember that we don't have just nicotinic receptors. We got some muscarinic receptors there too, in the same neighborhood. So if I increase acetylcholine for its nicotinic effects, the muscarinic effects can show up. And if those muscarinic effects happen to be at the heart, or at the lungs, or at the GI tract, because we've got muscarinic receptors, because what is acetylcholine? It is the neurotransmitter for the parasympathetic nervous system. So it's used for slowing stuff down. Slowing stuff down. All right? Precautions, contraindications. Yeah. If your GI tract if you've got blockage, all right, or if you have asthma, I'm going to give you a medication that's going to increase acetylcholine levels. So can you imagine a patient that has a diagnosis of asthma, grew up with asthma, and then develops myasthenia gravis? Okay? That's a bad day. Okay? So are we not going to treat them? Absolutely not. We're going to treat them. But we're going to watch them really closely. Okay? See how they tolerate our treatment. All right? So, muscarinic antagonists, well, okay, because the muscarinic antagonists that we have, all right, we'll learn about those later. Just know that neostigmine has a drug interaction with muscarinic antagonists and non-depolarizing neuromuscular blockers. Those are the paralytic agents. And where do the paralytic agents work? At the motor end plate. Okay. So if I'm giving neostigmine, we may have to, and you have to go to surgery, and I need you completely paralyzed, I may have to give you bigger doses. Okay? Now, the other reversible, so physostigmine, somebody asked me about physostigmine. Why don't we use that? Because physostigmine crosses the blood-brain barrier. It's lipophilic. All right? Edrophonium, we actually use that as part of our, is it a myasthenic crisis or are they in a cholinergic crisis? Okay? And we use the half-life, edrophonium's got a really short half-life. So you may have to deal with their which way they go for about 20, 30 minutes. Okay? And it's also used, well, we think you have myasthenia, so I'm going to give you this drug and watch you. Do you get myasthenic crisis? Do you get better? Or do I make you sicker? Do I poison you? Here, you'll need to sign this informed consent because I'm getting ready to either make you better or poison you. And most patients go, well, I vote for getting better. All right? But, and all of the drugs to treat Alzheimer's disease are reversible cholinesterase inhibitors. And we're going to come back to that. Okay? All right, at this point, I figured I'd finish early. I'm going to hand back homework for those that didn't pick it up.